Hello, and welcome to our webinar on documentation in the Inpatient Rehabilitation Facility. My name is Jennifer Boniface, and I am one of the nurse analysts with the Provider Outreach and Education team. Today's webinar will focus on inpatient rehabilitation facility coverage criteria and documentation needed for an inpatient rehabilitation facility or IRF stay. On the next slide, we have our disclaimer. It states that this education is for informational purposes only. Medicare rules change often, so please make sure you are looking at official CMS communications for the most up-to-date rules and regulations. These do take precedence over anything that is presented today. And as a reminder, CMS prohibits recording of this presentation for profit-making purposes. This presentation is being recorded by us and will be posted on the WPSGHA.com training page under Encore Presentations. On this slide, you will see a list of acronyms used in this presentation. During this presentation, if there are any acronyms you are unfamiliar with, please refer back to this slide for guidance. During today's webinar, to ensure comprehensive, accurate documentation for inpatient rehabilitation stays, we are going to review the specific coverage criteria used to assist with determining eligibility for IRF services. Additionally, we will discuss the necessary documentation needed to ensure proper reimbursement and delivery of high-quality care during an IRF stay. By the end of this webinar, you should have a comprehensive understanding of the key factors governing IRF coverage and documentation requirements necessary for an inpatient rehabilitation facility stay. So first, we will start with medical necessity. Documentation should show that the inpatient rehabilitation facility admission is reasonable and necessary. The patient's medical record needs to support the reasonable expectation that upon admission to the IRF, the patient required the intensive rehabilitation therapy services that can only be provided in an inpatient rehabilitation facility. Documentation should support why care from a lower level of care, such as skilled nursing facility or home health, is inadequate or inappropriate for the patient's clinical situation. It should also be able to demonstrate that participation in intensive rehabilitation at an IRF will improve the patient's functional capacity and adaptation to impairments within a prescribed period. Please remember to avoid vague or subjective descriptions when documenting in the patient's medical record. Per the IOM 100-02 Medicare Benefit Policy Manual, Chapter 1, Section 110.3, the patient's IRF medical record needs to indicate both the nature and degree of expected improvement and the expected length of time to achieve the improvement. You can find a link to the IOM 100-02 Medicare Benefit Policy Manual, Chapter 1 on this slide, as well as the resources slide at the end of this presentation. We will review what is necessary to fulfill this requirement as we discuss coverage criteria and documentation requirements for the inpatient rehabilitation facility. Next, let's review coverage criteria needed for the inpatient rehabilitation facility stay. In order for the IRF stay to be considered reasonable and necessary, the documentation upon admission to the inpatient rehabilitation facility needs to show a reasonable expectation of the patient's need for the following criteria. First, complexity of the patient's nursing services. Documentation should focus on how the involvement of the rehabilitation nurse contributed to the overall need of the patient's rehabilitative stay. This may include documentation on how rehabilitation nursing reinforced the skills taught and learned during therapy, patient, family, and/or caregiver education related to the IRF stay, and performance of nursing procedures required during the IRF stay. Next is closed physician medical management, including the requirement for physician supervision and face-to-face visits. We will discuss this requirement in further detail in a little bit. Third is an interdisciplinary team approach for rehabilitation in order to develop a comprehensive plan of care and treatment tailored to the needs for each patient. Next is the intensity of services needed. The documentation should show that the medical condition and/or diagnosis for admission would necessitate an intensive rehabilitation therapy program. A list of qualifying conditions can be found in the Code of Federal Regulations 42 CFR 412.29B2. We will not be discussing these conditions today, but a link to this section of the CFR will be added to the chat as well as the resources slide at the end of this presentation for you to reference. And finally is therapy service intensity. Documentation should reflect the patient is receiving the required amount of therapy to meet the definition of intensive therapy. We will discuss this requirement in further detail in a little bit. So now I'm going to go into the Medicare Benefit Policy Manual. According to the IOM 100-02 Medicare Benefit Policy Manual, Chapter 1, Section 110.2, the documentation in the medical record must show a reasonable expectation at the time of admission that the following criteria were met. The patient requires active and ongoing therapeutic intervention of multiple therapy disciplines. The patient requires an intensive rehabilitation therapy program. We will define this requirement more in a little bit. The patient is stable enough to meet the expectation to actively participate in and benefit from an intensive rehabilitation therapy program. The patient requires physician supervision by a rehabilitation physician. And the patient requires an intensive, coordinated, interdisciplinary rehabilitation approach. In the next several slides, we'll take a more in-depth look at each of these reasonable expectations. The first reasonable expectation requirement is active and ongoing therapeutic intervention of multiple therapy disciplines. The patient requires active and ongoing therapeutic intervention of multiple therapy disciplines such as physical therapy, occupational therapy, speech-language pathology, and/or prosthetics and orthotics. Please note that this requirement states that one of the disciplines providing therapy must be either PT or OT. The next requirement is for intensive rehabilitation therapy program. Per the IOM 100-02 Medicare Benefit Policy Manual, Chapter 1, Section 110.2, the patient generally requires an intensive rehabilitation therapy program. This is defined as usually consisting of at least 3 hours of therapy per day for at least 5 days per week. However, in certain situations, the intensive rehabilitation therapy program might instead comprise of at least 15 hours of intensive rehabilitation therapy within a 7 consecutive calendar day period, starting with the IRF admission date. An example of this may be an intensive rehabilitation therapy schedule of 3 hours of therapy 3 days a week and 2.5 hours of therapy on 3 other days per week to allow the patient to receive an unrelated medically necessary treatment such as chemotherapy or intravenous infusion of blood products. It is important to clearly document this situation should it arise. The required therapy treatments must also start within 36 hours from midnight of the day of admission to the inpatient rehabilitation facility. In the IRF, completion of the therapy evaluations indicates the beginning of the required therapy services. The treatment minutes should be documented in the medical record. This documentation includes the type of therapy treatment received. Individualized treatment must make up the majority of treatment minutes. The patient may participate in group and concurrent treatment, and those minutes can be counted toward meeting the intensity requirement as a supplement to the individualized therapy minutes. However, the majority of minutes must be from individualized treatment. The majority of minutes cannot be from group or concurrent treatment. So let's discuss the differences between individualized versus group versus concurrent therapy treatment. Individualized therapy is defined as one therapist to one patient. This is what a majority of the treatment minutes should be comprised of. Group therapy is defined as one therapist treating two or more patients at the same time. With group therapy, the patients are performing the same activity. Concurrent therapy is defined as one therapist treating two patients at the same time while the patients are performing different activities. A justification explaining the situation or rationale for group or concurrent therapy versus individualized therapy should be documented in the patient's medical record. We will discuss documentation requirements for therapy later on in this presentation. Ability to actively participate is the third reasonable expectation requirement. A patient should be stable enough to meet the reasonable expectation to actively participate in and benefit from an intensive rehabilitation therapy program. Medicare does allow for brief breaks in therapy when a patient has an unexpected condition that limits the patient's ability to participate in the intensive rehabilitation program under the brief exception policy. These brief breaks should not exceed 3 consecutive days. The reason for the break in providing therapy services must be documented in the patient's IRF medical record. Some reasons include extensive diagnostic tests off premises, prolonged intravenous infusion of chemotherapy or blood products, bed rest due to signs of deep vein thrombosis, exhaustion due to recent ambulance transportation, and surgical procedures. The determination of medical necessity for the inpatient rehabilitation facility admission should generally not be affected as long as the reasons for the break in service are clearly documented in the patient's IRF medical records. However, please note that Medicare does not allow the brief exception policy to be used during the first 3 days of the patient's admission to the inpatient rehabilitation facility. The requirement for rehabilitation physician supervision is next. There needs to be documentation in the patient's medical record of supervision by the rehabilitation physician. The rehabilitation physician is a licensed physician with specialized training and experience in inpatient rehabilitation. It is the responsibility of the IRF to determine whether the rehabilitation physician meets training and experience requirements. Per 42 CFR Section 482.24 C4IA, Conditions of Participation, a medical history and physical needs to be completed by the physician. You can find a link to this section of the CFR on conditions of participation on this slide, as well as the resources slide at the end of this presentation. The medical history and physical should document the patient's status on admission within 24 hours after the IRF admission. Any changes observed should be documented by the IRF physician in the doctor's notes. Documentation needs to support the medical necessity of the inpatient rehabilitation facility admission. The physician reviews the documentation obtained, then develops the expected course of treatment for the patient. The rehabilitation physician must perform face-to-face visits with the patient at least 3 days per week throughout the patient's IRF stay. The patient should be assessed both medically and functionally. A non-physician practitioner, or NPP, with specialized training and experience in inpatient rehabilitation can perform one of the 3 required weekly face-to-face encounters with the patient starting the 2nd week to the inpatient rehabilitation facility stay. The duties of the IRF non-physician practitioner must fall within the NPP's scope of practice under applicable state law. The inpatient rehabilitation facility needs to determine whether the non-physician practitioner meets training and experience requirements. Any changes observed should be documented by the IRF physician in the doctor's notes. Additionally, modifications to the course of treatment should be completed as needed by the rehabilitation physician to allow the patient to receive the maximum benefit from the rehabilitation process. All documentation completed by the rehabilitation physician and non-physician practitioners, including the face-to-face visits, should be placed within the patient's medical record. We did receive a pre-submitted question asking clarification about who can perform the face-to-face visits, so I want to answer that before we move on. The question asks, who can perform the face-to-face visits for the patient? Can a nurse practitioner that works with the rehabilitation physician complete them? Starting the 2nd week of admission to the IRF, a non-physician practitioner, or NPP, with specialized training and experience in inpatient rehabilitation can perform one of the 3 required weekly face-to-face encounters with the patient. The duties must fall within the non-physician practitioner's scope of practice under applicable state law. The nurse practitioner in this situation can complete one of the 3 required face-to-face visits starting the 2nd week of admission as long as the rehabilitation physician is completing at least 2 of the 3 remaining face-to-face visits in order to fulfill the Medicare requirement. Documentation of all face-to-face visits should be placed within the patient's medical record. Documentation in the medical record should show a continued need for inpatient care. The nursing staff needs to document the patient's progress daily in their nurse's notes. Any assessments performed should also be documented in the patient's medical record. Finally, the last reasonable expectation is an intensive and coordinated interdisciplinary rehabilitation approach. The purpose of the interdisciplinary team is to collect data about the patient and develop and assess goals to guide the treatment of the patient during the IRF stay. This process requires an intensive and coordinated interdisciplinary rehabilitation approach to facilitate frequent, structured, and documented communication among the various interdisciplinary team members. The interdisciplinary team conferences need to be held at least once a week. It can be performed either formally or informally. However, all treating professionals or a qualified designated representative of the treating discipline must be at every meeting. These conferences should include the following health professionals: the rehabilitation physician, a registered nurse with specialized training or experience in rehabilitation, a social worker or case manager, or both, and licensed or certified therapists from each therapy discipline involved in treating the patient. The rehabilitation physician leads the interdisciplinary team and develops the individualized plan of care with input from the interdisciplinary team. This can be done either in person or remotely through video or telephone conferencing. The rehabilitation physician is responsible for all final decisions about the patient's treatment plan made during the interdisciplinary team meeting. The name and credentials of all participants in each interdisciplinary team meeting should be documented. CMS regulations requires the rehabilitation physician to sign and confirm agreement with decisions made by the interdisciplinary team. However, it is not a requirement for each member of the interdisciplinary team to individually sign each team's meeting's documentation. All decisions made during each interdisciplinary team conference should be documented in the patient's medical record. So now that we know the coverage criteria, let's review documentation requirements for the inpatient rehabilitation facility stay. The documentation requirements for the IRF are listed on the next two slides of the presentation. They include a pre-admission screening completed and or updated within 48 hours, an IRF admission order, an individualized plan of care completed within 4 days of admission and synthesized by the rehabilitation physician, documentation of the patient's need for intensive rehabilitation therapy services, completion of the Inpatient Rehabilitation Facility Patient Assessment Instrument, or IRF-PAI, therapy evaluations, treatment notes, treatment records, interdisciplinary team conference records, physician orders and progress notes, nursing progress notes and assessments, social work and or case management notes, acute care records, and advanced beneficiary notice of non-coverage ABN if applicable. Please note, effective for discharges on or after October 1st, 2020, the post-admission physician evaluation documentation requirement was removed from the fiscal year 2021 IRF-PPS final rule. So let's first start by discussing the comprehensive pre-admission screening. The comprehensive pre-admission screening is the primary source of documentation of the patient's status prior to admission to the inpatient rehabilitation facility. It is used to assist with determining the appropriateness of the admission. The comprehensive pre-admission screening should demonstrate the exact reasons that led the IRF clinical staff to determine that the inpatient rehabilitation facility admission would be reasonable and necessary. This can be completed through detailed and thorough documentation. A comprehensive pre-admission screening can be performed either in person or through a review of the patient's referring hospital medical records when hospital stay precedes the IRF admission. If the pre-admission screening is conducted by phone, the patient's medical record from the referring hospital must be retained in the patient's medical record at the inpatient rehabilitation facility. Again, avoid using vague or subjective descriptions when documenting the patient's needs. A comprehensive pre-admission screening needs to be completed within 48 hours prior to the IRF admission. This allows the rehabilitation physician and the facility to get a better picture of the potential patient and facilitate the decision-making process for admission. If the pre-admission screening is performed more than 48 hours prior to admission, it will be accepted as long as an update is performed either in person or by phone to document the patient's medical and functional status within 48 hours prior to the IRF admission at the inpatient rehabilitation facility. The update should be placed in the patient's medical record. The pre-admission screening should consist of a detailed and comprehensive review of each of the patient's conditions and medical history. It needs to be performed by a licensed or certified clinician. The rehabilitation physician may appoint or designate a qualified, licensed, or certified clinician to conduct the pre-admission screening. A qualified licensed or certified clinician is considered as a person that is appropriately trained and qualified to assess the patient's medical and functional status, assess the risk for clinical and rehabilitation complications, and assess other aspects of the patient's condition, both medically and functionally. It is the responsibility of the inpatient rehabilitation facility and the rehabilitation physician to determine and make sure that these designated individuals have the necessary training and qualifications. The pre-admission screening should provide an accurate assessment of the patient's ability and willingness to actively participate in intensive rehabilitation at the start of care. Documentation must indicate the patient's prior functional level before the event or condition causing the need for intensive rehabilitation therapy, an expected level of improvement, expected length of time necessary to achieve that level of improvement, evaluation of the patient's risk for clinical complications, conditions that cause the need for rehabilitation, expected frequency and duration of therapy treatments needed, anticipated discharge destination, any anticipated post-discharge treatments, other information relevant to the patient's care needs, and the name of the professional performing the pre-admission screening. The rehabilitation physician must either physically or electronically sign, date, and time the pre-admission screening or a separate statement documenting review of the findings and results of the pre-admission screening and concurrence with the admission decision. All documentation collected during the pre-admission screening process must be placed in the patient's medical record at the inpatient rehabilitation facility. This includes any documentation obtained from the referring hospital or any other relevant prior inpatient hospital stays. Documentation should show that the admission decision was made prior to the patient admission and the rehabilitation physician reviewed the admission decision and agrees with the findings and results of the pre-admission screening prior to the inpatient rehabilitation facility admission. It is the IRF's responsibility to ensure that the admission decision is documented in the patient's medical record. On our YouTube page, we have created a video with more information about the comprehensive pre-admission screening. I've included a link to this YouTube video on the resources slide at the end of this presentation. We have a few pre-submitted questions on the pre-admission screening and admission decision that I want to go over before we move forward. Question number 1 asks, can you clarify who is allowed to perform a pre-admission screening? Can it be an admission representative from our hospital? The pre-admission screening needs to be performed by a licensed or certified clinician. A licensed or certified clinician is a person that is appropriately trained and qualified to assess the patient's medical and functional status, assess the risk for clinical and rehabilitation complications, and assess other aspects of the patient's condition, both medically and functionally. It is the responsibility of the IRF and the rehabilitation physician to determine that these individuals have met the necessary training and qualifications to perform the pre-admission screening. If the admission representative at your facility does not fall under the description of a licensed or certified clinician, that person would not be qualified to perform the pre-admission screening. Question 2 asked, is there a standardized form CMS requires for the pre-admission screening? CMS does not provide a standardized form to use for the pre-admission screening, nor does CMS require the use of a standardized form for the pre-admission screening. CMS allows each inpatient rehabilitation facility to determine how best to meet the documentation requirements for the pre-admission screening. However, use of check boxes such as yes/no boxes on the pre-admission screening would not suffice. It must include some narrative information when describing the patient. The narrative description can be written either by the rehabilitation physician or the licensed or certified clinician performing the pre-admission screening. Documentation of the rehabilitation physician's review and concurrence with findings and results of the pre-admission screening should also be included in the documentation in the patient's medical record. Please note that this documentation requirement applies to both patients admitted to the IRF from another healthcare facility, as well as patients admitted to the IRF from the community. Also remember the pre-admission screening is considered a permanent part of the patient's medical record and should be placed accordingly. Question 3 asks, can a nurse practitioner in the same practice with a rehabilitation physician make the admission decision for the IRF in the absence of a rehabilitation physician? While a non-physician practitioner, such as a nurse practitioner, may perform the pre-admission screening, The decision on whether the patient meets the criteria for admission to the IRF must be made by the rehabilitation physician. Since the admission decision requires a physician's determination, the admission decision cannot be delegated to a non-physician practitioner, such as a nurse practitioner. The rehabilitation physician needs to review the admission decision and agree with the findings and results on the pre-admission screening prior to the IRF admission. The rehabilitation physician should clearly document the review and concurrence with the findings and the result of the pre-admission screening prior to the patient being admitted to the inpatient rehabilitation facility. In rare circumstances that the rehabilitation physician is unavailable, such as an unplanned illness, a physician designated by the IRF can substitute and perform the review of findings and results of the pre-admission screening, then document the concurrence with the admission decision in the patient's medical record. The reason why the rehabilitation physician did not document review and concurrence with the admission decision must also be documented in the patient's medical record. Question 4 asked, when and how must the admission decision be made by the rehabilitation physician? The potential patient is evaluated using the comprehensive pre-admission screening. It must be completed prior to the patient's admission to the IRF. Documentation in the patient's medical record needs to show that the rehabilitation physician reviewed the admission decision and concurs with the findings and results of the pre-admission screening prior to the IRF admission. This means prior to the patient's admission to the inpatient rehabilitation facility, the rehabilitation physician must either physically or electronically sign and date the pre-admission screening or a separate statement documenting review of the findings and results of the pre-admission screening and concurrence with the admission decision. While the rehabilitation physician can review and document concurrence with each component of the pre-admission screening, this is not required as long as the rehabilitation physician documents concurrence with the pre-admission screening as a whole. It is the IRF's responsibility to ensure that the admission decision is documented in the patient's record. And the fifth and final question for this section is, if it is decided upon review of the pre-admission screening not to admit the potential Medicare beneficiary as a patient to the inpatient rehabilitation facility, do we need to retain the IRF referral documentation for that potential Medicare patient? While it is required to maintain all documentation for Medicare beneficiaries that are admitted to the inpatient rehabilitation facility, if a Medicare beneficiary is not admitted to the inpatient rehabilitation facility, the IRF is not required to keep the IRF referral documentations for that non-admitted Medicare patient. So let's move on. Next, we will discuss an IRF admission order. A physician order is required for an inpatient rehabilitation facility stay. An IRF admission order must be present in the patient's medical record. The admission order must be signed by the physician as well as dated and timed. It must be authenticated by the author using either a handwritten or electronic signature. Stamped signatures are not acceptable. The only exception to this rule is in a case of an author with a physical disability who can provide proof to the CMS contractor of their inability to sign their name due to a physical disability. By using the rubber stamp as a method to sign, the physician is confirming their thorough review of the documentation. The order needs to have enough documentation to determine the date on which the service was performed. However, medical review can reasonably assume the date of entry if the entry immediately above or below is dated. We did receive a question on admission orders prior to this webinar that I'm going to answer right now. Who can generate an admission? The question asks, who can generate an admission order for a patient? Does it have to be a rehabilitation physician, or can it be another physician to provide the admission order? Any licensed physician can generate the admission order. A non-physician practitioner working in collaboration with the physician may also generate the admission order. Additionally, the physician can verbally give an admission order as long as the verbal admission order is transcribed and retained in the patient's medical record. all admission orders must be signed, dated, and timed to be valid. The third documentation requirement is an individualized overall plan of care. The overall plan of care is developed by the interdisciplinary team. It should be developed using data collected from the pre-admission screening, as well as any data from assessments completed by all treating disciplines. The overall plan of care should be individualized for each patient and take into account the patient's care and therapy needs, as well as the patient's medical history. This includes patient's impairments, functional status, complicating conditions, and any other contributing factors that may influence the patient's treatment plan. The overall plan of care should contain documentation about the patient's medical prognosis and anticipated interventions, functional outcomes, and discharge destination from the IRF stay in order to support the medical necessity of the inpatient rehabilitation admission. An individualized overall plan of care must be completed within the first 4 days of the inpatient rehabilitation facility admission. Per the IOM 100-02 Medicare Benefit Policy Manual, Chapter 1, Section 110.1.3, the documentation for therapy should include expected intensity or number of hours per day, frequency or number of days per week, and duration or total number of days of physical, occupational, speech-language pathology, and or prosthetics and orthotics for the IRF stay. CMS regulations requires the rehabilitation physician to sign and confirm agreement with decisions made by the interdisciplinary team within 4 days of the inpatient rehabilitation facility admission. They do not require members on the interdisciplinary team to individually sign each team meeting's documentation. I'm now going to go over a couple pre-submitted questions we received about the individualized overall plan of care. Is there a standardized form that can be used when creating the overall plan of care? CMS does not provide a standardized form to use for the overall plan of care, since it should be individualized for each patient to best reflect the patient's medical and functional care needs. CMS allows each inpatient rehabilitation facility to decide how best to meet the documentation requirements for an individualized plan of care to address the medical and functional care needs of each patient. Question 2 asks, does the interdisciplinary team need to meet within the first 4 days of admission? While the plan of care must be completed by the end of the 4th day immediately following the IRF admission, the interdisciplinary team does not have to meet within those first 4 days of admission. The physician is responsible for gathering and analyzing all patients' medical and functional needs and goals, then establishing the plan of care within the first 4 days of admission to reflect these findings. The rehabilitation physician can either develop then create the entire plan of care, or can gather the individual plans of care from the different treating disciplines and then modify or add these individual plans of care as needed. A non-physician practitioner can assist the rehabilitation physician in developing the overall plan of care for the physician's approval and signature. However, it is good practice for the interdisciplinary team to meet and assist with establishing the plan of care so all patient care needs are appropriately addressed in the plan of care. The next requirement is documentation of the patient's need for intensive rehabilitation therapy services. We discussed the requirements earlier in this presentation when we discussed IRF coverage criteria. However, I want to briefly review this information before moving forward, since it is a crucial component of the IRF documentation. Per the IOM 100-02, Chapter 1, Section 110.2, the patient generally requires an intensive rehabilitation therapy program. This is defined as usually consisting of at least 3 hours of therapy per day for at least 5 days per week. However, in certain situations, the intensive rehabilitation therapy program might instead comprise of at least 15 hours of intensive rehabilitation therapy within a 7 consecutive calendar day period starting with the IRF admission. Again, make sure to clearly document this situation should it arise. And remember, the required therapy treatments must also start within 36 hours from midnight of the day of admission to the inpatient rehabilitation facility. The medical record should include daily treatment records from each treating therapist or therapy assistant. The treatment record should include documentation on the time of the rehabilitation therapy, the total time of the rehabilitation therapy, the therapy disciplines provided, and please remember that it is required that the patient must be receiving at least physical therapy or occupational therapy, time spent on each activity, and the patient's response to the therapy. Also, don't forget to include the type of therapy treatment received during therapy sessions, such as individualized therapy minutes versus group or concurrent therapy minutes. You can use other documentation within the patient's medical chart, such as therapy evaluations, the patient's plan of care, physician notes, nursing notes, patient assessments, and interdisciplinary team meeting reports and notes to assist with supporting the level of therapy required for an intensive rehabilitation therapy program. Before we move on to the last documentation requirement, I am going to answer a few pre-submitted questions we received about therapy documentation. Question number 1 asked, can the expected amount of therapy time vary day to day? To accurately reflect the individualized medical and functional care needs of the patient, the overall plan of care should include documentation of the type and expected amount of physical therapy, occupational therapy, speech-language pathology, and orthotics and prosthetics needed by the patient daily. Day-to-day variations in the expected amount of therapy are acceptable as long as the patient's individualized care needs are being addressed. Question 2 asked, we had a patient that was put on bed rest for 48 hours to rule out a DVT, so she missed therapy for those days. She was cleared to resume intensive therapy following those 48 hours. Will this break in therapy affect her eligibility to remain in the IRF? In order for the patient to meet the medical necessity requirements for the inpatient rehabilitation facility, the patient should be stable enough to meet the reasonable expectation to actively participate in and benefit from an intensive rehabilitation therapy program. However, under the brief exception policy, Medicare does allow for brief breaks in therapy when the patient has an unexpected condition that limits the patient's ability to participate in an intensive rehabilitation program. These brief breaks should not exceed 3 consecutive days. Make sure to clearly document the reasons for the break of providing therapy services. The determination of medical necessity for the IRF admission should generally not be affected as long as the reason for the break in service are clearly documented in the patient's IRF medical record. However, remember, Medicare does not allow the brief exception policy to be used during the first 3 days of a patient's admission to the IRF. Question 3 asked, if a patient is unable to attend therapy for at least 3 hours a day for 5 days a week due to regularly scheduled IV antibiotic therapy every other day, can this intensive therapy be broken up to accommodate this patient's medication schedule? To qualify for an IRF, the patient must require intensive rehabilitation therapy services that can only be provided in an inpatient rehabilitation facility setting and are not able to be provided at a lower level of care, such as a skilled nursing facility or home health. Intensive rehabilitation therapy services usually consist of at least 3 hours of therapy per day for at least 5 days per week. However, in certain situations, the intensive rehabilitation therapy program might instead comprise of at least 15 hours of intensive rehabilitation therapy within a 7 consecutive calendar day period, starting with the IRF admission date. An example of this may be an intensive rehabilitation therapy schedule of 3 hours of therapy 3 days a week and 2 hours of therapy 3 to 4 other days a week to allow for the patient to receive the IV antibiotic therapy. It is important to clearly document this situation should it arise. We are now on the last documentation requirement we will be discussing today. completion of the Inpatient Rehabilitation Facility Patient Assessment Instrument, or IRF-PAI. Completion of an inpatient rehabilitation facility patient assessment is required. The IRF-PAI collects patient assessment data for quality measurement, calculation, and payment determination. It is part of the IRF Quality Reporting Program. The facility must complete the inpatient rehabilitation facility patient assessment and patient admission and discharge. The information in the IRF-PAI must match with all information provided in the patient's IRF medical record and support appropriate claim coding. It should be dated, timed, and authenticated by the person documenting within it and placed in the patient's electronic or paper medical record in the inpatient rehabilitation facility. So as a review, during today's webinar, we reviewed the coverage criteria needed for the IRF stay, as well as discussed the documentation requirements necessary for an inpatient rehabilitation facility stay. I have included some CMS and WPS GHA resources at the end of the slide deck about the information we discussed today. We won't be reviewing them, but I want to make sure you have them. Please use them as a reference when reviewing the presentation. We are now at the end of the formal presentation. We will have a follow-up webinar on November 21st at 9 a.m. Central Time, 10 a.m. Eastern Time to review documentation examples as well as answer any follow-up provider questions. Please remember, if you have any questions, please put those questions in the chat feature and select Send to all panelists. So Rachel, do we have any questions in the chat?
Hi, Jennifer. It's actually Mary Sue. Yeah, we've had several questions come through, and some of these I have answered to those individuals, but I wanted to kind of provide an answer to the group as a whole. We've had a lot of questions come through about the history and physical component of the services. So as Jennifer had said, you know, for the PAI for the post-admission physician evaluation, that requirement was removed. However, the history and physical component is still required under the conditions of participation. So when you go to your 42 CFR conditions of participation, you know, it basically gives you that general information about your history and physical exam and that it needs to be completed and documented, et cetera. There's no requirement in that for a specific person to do that or a specific physician. So really when we talk about the H&P, that can be done by the internal medicine physician at the hospital. That can be done by one of your non-physician practitioners. But the important part is, remember, it is the responsibility of the inpatient rehab physician to support in their documentation that they have reviewed that information and that they're using it as a part of their consideration for admission into that type of facility. So they're using, again, they have to somehow note that they have reviewed that information and that it is part, you know, it's evident that it's part of their decision to admit the patient. Sometimes diagnoses may be different, or reasoning for the hospital and the inpatient rehab facility may be different. Again, it comes down to the responsibility of the inpatient rehab physician to support in their documentation what it is that necessitates the need for this intensity of services. So I think that takes care of a lot of the questions, Rachel, or Jennifer, I'm sorry. I just wanted to quickly go through that. Let's see. Let me get to, there was a question about for the update to the pre-admission screen. If the pre-admission screening was done longer than 48 hours ago, is the 48 hours calculated by the date and screen was completed or when the physician signed the original pre-admission screening?
The pre-admission, the admission, let me try this again. If the pre-admission screening is completed and signed more than 48 hours prior to admission, it does need an update. I'm not sure if that clarified what you're asking. Am I answering that question?
I think they were asking about the date and time. We would go by the date that it is actually noted that it was completed and not necessarily the date that it was signed off by the physician for review. So that's the date for that pre-admission screening, you know, that 48 hours, we're looking to see if the patient is actually a different patient for 48 hours later. If there's been changes in their physical abilities, their medical conditions, etc. So the date that we would use would not necessarily be the signature date, it would be the completion date. Sorry, I probably didn't read that very well, Jennifer. Let me see what else. All right. And this kind of, there was a question from Ashley. In the case there's a discrepancy in impairment group code diagnoses necessitating the rehab admission between like the internal medicine doctor and the rehab doctor, who's responsible for that. And again, the ultimate decision and the proof of necessity comes down to the rehab physician. All right. I'm sorry, I answered some of these to those individual askers, not knowing of the amount of time we'd have. So I'm just kind of scrolling down. Okay, Jennifer, for the pre-admission decision, is signature enough on the pre-admission screening to justify the agreement or concurrence of the patient's admission, or does it need to be documented as a statement that they agree and then sign as well?
If the physician signs the pre-admission screening, they're denoting that they've reviewed it and they concur with the decision. But if they don't sign it, then you would need that separate statement, you know, saying that they reviewed it and they concurred with it.
Perfect. Okay, so the next question, if a brief exception policy cannot be used during the first 3 days of the IRF stay, how should the IRF manage in the case that a patient is not able to meet the 3-hour requirement rule within the first 3 days? For example, a new stroke, symptoms, rule out DVT, etc.
If they are not able to participate within the first 3 days, they wouldn't qualify for the IRF stay. The requirement does require them to meet the 3 hours a day for 5 days a week or 15 hours a week for them to even qualify for the IRF stay. So if they're not doing that within the first 3 days, then they could not apply the brief exception policy and they would not meet the qualifications to be admitted to the IRF.
Yeah, so that old ramp up period was gone. They have to meet it right at the day one when they're walking in the door. When discussing therapy initiation, is it the expectation that all therapy disciplines ordered be initiated within 36 hours of midnight of the day of admission? Or would it be considered okay to only have one discipline initiated at the time frame provided that the patient met the, you know, for therapy intensity requirements?
At least one, it has to be either PT or OT, but as long as one of them has initiated within that time frame, that should be suffice.
And then a couple, we are right at the end of time, but I'm just going to read this and answer it so it can flow real quick. For therapy treatment records, does therapy time for each session need to be listed on the treatment note? The answer to that is yes. The time and minutes of actual therapy provided, not the time just into the physical therapy area and out of the physical, but actual amount of minutes of time of one-to-one therapy. And how do we sign up for the review of documentation session? So if you go to our website at WPSGHA.com and you go to the training page and you select live events, you can then register for the next event right from our training page, and you can also download the material. So I think we have answered all of the questions, but that takes us to the end of our time, Jennifer. So if you want to go ahead and move on with closing statements, we can wrap things up.
On behalf of myself and Provider Outreach and Education, thank you for attending today's webinar on documentation in the inpatient rehabilitation facility. Remember, this presentation will be posted as an encore presentation on our training page at WPSGHA.com. Don't forget to join us for our webinar on November 21st. We will be reviewing some examples of inpatient rehabilitation facility documentation. Remember to take our survey with the link provided. We look forward to your survey comments and hope to have you join us at future events. You may now disconnect.